really good job of adding text where the narrator started to mumble or tail off, so everyone knew what he was talking about. Really, we've covered all this information in the audio-video clip, but it is a 6-bed adolescent psychiatric hospital that we're going through and seeing in that type of setting. It's really not a hospital setting. We tried to replicate the home environment as much as we can within a mental health treatment setting. In terms of preparing for discharge, once the kids have went through the program and had the assessment completed, we're looking at what outpatient services are appropriate. So how can we keep the child and family on track, monitor their mental health, and hopefully make some real gains in terms of their functioning. So the Children's Center, again, is our key partner here, and they're always present whenever we have our team meetings to talk about the kids in the program, what they're dealing with, what are the key issues, and how they're likely to respond to outpatient therapy, and what type of therapy is best suited for them. All of this information is reviewed with the family prior to discharge. And then on discharge, it's kind of, we put it back on the family to make contact with the Children's Center and say, hi, I'm so-and-so's parent, and we just had our inpatient assessment completed, and the service coordinator knows who they are and is ready for the call and sets them up with their outpatient counselor. Typically, we're looking at 7 to 14 days wait time for outpatient services. If you're trying to access outpatient services without this inpatient assessment, it can be in the neighborhood of 6 months, although we're trying to work on getting that time down as well. When we're looking at discharge, one of the 2 social workers that we mentioned in the clip is going to notify the parent of the plan. And again, if it's easier to think of it really from a hospital or medical model, it's that kind of process. It can be pretty quick. The doctor says, okay, they're ready for discharge. And then the case manager picks up, notifies the family, goes through safety planning with the child and the parent. So important things to talk about before the kid goes home would be, how can we keep the environment safe at home? We want to lock up medications, make the environment one that's still home-like, but one that's not going to put them at any undue risk or unneeded risk. If there's medication or things like that are going to be either started or continued when the child leaves the hospital, the nurse is going to meet with family, review the plan, and give the proper information around those type of things. Family doctor is also an important piece of the treatment model. They're aware of the child's admission to the hospital, and they're aware when they're discharged. We always encourage family to make an appointment within a month to follow up with their physician. Really critical if there's medications being initiated or adjusted, but also a good idea just to have your practitioner in the loop for this type of assessment process. From time to time, outpatient psychiatry is going to be needed once the child is discharged. The psychiatrist that's responsible in our program can make that referral or sometimes continue with the patient themselves. In terms of outpatient psychiatry, this program's really helped us in being able to recruit child and adolescent psychiatrists to the area. At the onset of this program, there was one 75-year-old child and adolescent psychiatrist in this area. He lived in Michigan. He was on call 24/7. He was terrific, but he was only one person, and it gets to be a demanding spot. And over time, we've been able to recruit 5 psychiatrists to the area that work directly with our program, share on-call responsibilities, and consult as needed. Real obvious or important things that have come out and have been noticed since this model's been put into place is that times in the emergency room, wait times especially, have been reduced. Again, when the child or family presents in a mental health crisis, the triage nurse gets the assessment process started right away, so they're not sitting and waiting. It's also freeing up nurses and physicians in the ER and allowing them to focus on other patients that have strictly physical medical issues. So young people that are dealing with emotional or mental health issues are receiving the appropriate treatment from the appropriate provider. Statistics, really what we're looking at here, it paints a picture of how busy we are. The statistics for this year only go up to September because this was compiled for a different purpose, but there really won't be a major difference. Aside from January and February, instead of 25, 24 admissions, we were over 30 this month. We did this talk in the city 2 weeks ago, And I had said that at that time, this school year, we've had 190 admissions into our program. As of right now, we've now had 206. So we've had more than one admission per day in the month of May. Our most common age of kid that we see or providing the assessment for is the 14, 15-year-old group. In the past, we've been able to accept 16, 17-year-old clients. Recently, we've shifted away from that, and that's just based on the demand for the beds for kids 15 and under. You can see the trickle down. There are the odd kid that is, really young, 5, 6, 7 years old. Those situations are pretty rare, and usually there's a real behavioral or safety component there. It's not strictly suicidal ideation or any of the things that Phil talked about, but there's some other things that might lead to an admission for a kid that age. The big thing we've picked up on, or that's become quite obvious to us, is that we're serving more and more families and kids, and the assessments are being done really efficiently, and kids are going back to school quickly. So that's become an area that we really want to look at in terms of supporting the schools and making sure that they're aware of what's going on with the kids when they come back and what's happened with the assessment. Again, this is just really information that we all know, is that mental health issues are a real concern for the adolescent population. Anxiety, mood, and conduct are all areas that educators have rated as real areas of concern for themselves. Not for themselves, but for the kids they see in their classes. What we're looking to do, again, is get the assessment done in 3 to 7 days. So that's quick, and that means the kids are coming back to school quick. What we found is that there was information that really could have been helpful for our assessment team to have from the schools that we were just missing because of the speed of things. And then again, information being exchanged at the back end of the assessment wasn't being done as often or as thoroughly as we'd like. So the school liaison service has been created really as a joint effort between Maryville and all of the school boards in this part of the province. What we're attempting to do with the school liaison is get information from the schools right away. So the child's coming in, the liaison's going to be in touch with the administrator, hopefully on day one, to talk about information really in 5 key areas that we know are important to our assessment being done accurately, and it's also important stuff for the school to get from us at the tail end. These are really the 5 key areas that we want to talk about or identify. If we can get information from the school, really, really helpful for our psychiatrists. So, the emotional functioning of the child, are there anything in terms of real red flags that stand out? Do they appear depressed? Are they isolated? Are there real behavioral or disciplinary things that jump out at you that say this kid's struggling or having a hard time with things? Academic workload can be a stressor if a child's misplaced or in the wrong stream. Attendance patterns, and then if we have previous assessments, we really want to know about that too. We want to keep the schools updated on the assessment, what's going on, what are we doing today, are we doing a psychoeducational assessment, are we looking at medication, what's it looking like in terms of timeline for the child's return. Again, if we can get schoolwork, we'll try and do that. Work's not a priority, but keeping a child in as normal a routine as possible is a priority, and that's what we're hoping to do with our classroom. At the tail end of the assessment, the liaison's going to get the school the important information. So is there diagnostic stuff that's important for the school to know? Are there medical things that really are important? Are there things that came out of the family history that would be helpful for the school to know, and how to support the child when they return? And then really, again, I guess the whole point of this is to be able to support the child better when they come back. So the more information we can share, ideally, the better we can support the kid when they return to school, both in terms of their academic situation in the classroom and also socially, just in the social environment at school. Some of the services we can provide or help out with, if there are safety behavior issues at the school, we can consult and give our input, or give the psychiatrist input in terms of the assessment. About 40% of our inpatients have a psychoeducational assessment done while they're with us. So If that's the case, we make sure that the school gets that information. Phil and his team will get the full report when it's complete, and if there's anything in terms of academic recommendations, accommodations, things like that that need to be identified or kind of worked out through the IPRC process, those are flagged out. At the tail end, again, really we're able to consult, so we're not going to be the key people in terms of supporting the child through their ongoing treatment. If the school's got concerns or having issues or seeing things that they want to talk to the provider about, that's typically going to be RCC or the other outpatient provider, but certainly we're available to consult in the 6 months following the time of discharge. And I think this is where Ms. Komar is going to pick up in terms of return to school.
So as Matt was saying, the relationship here is key for us in terms of knowing next steps. Sometimes the student will come back and there won't be any specific things that we have to do within the school. In other circumstances, we may develop in partnership with our community partners and the school personnel a safety plan. So how do we expect the staff to react in certain situations if things are presented by that particular student? And we often have a community case conference and bring all the key players together so that people understand exactly what's going on with that particular student. And if they are going for follow-up counseling through Regional Children's Center, then oftentimes those community case conferences will happen more than once so that we can update from the school's perspective the things that are happening, the progress that's being made, and the counselor that's involved at Regional Children's Center can also support us in terms of what strategies they're trying to work with that particular student on. And if we can mirror those within the school, it works really well. So if home and school and counseling are working together, then the child is getting the support that they need, and it's much more effective in terms of the treatment. Dr. Ricciardi had mentioned that our social work team had come up with a program that we're just starting this year. Actually, we're just starting this month. We, when you noticed the statistics, you saw the number of crisis calls. A great number of those crisis calls we get are individuals who are involved in self-harm behavior, so they're cutting. And what we started to see was groups of students in particular grade levels at particular schools that were involved in that behavior. And so we wanted to try to deal with it in more of a preventive way instead of a reactive way. And what we've done is we've created an opportunity for grade 6 and this year the grade 7 teachers to utilize the social workers. So the teacher themselves have an activity that they do with their class, and it focuses on the various stressors that the kids are going through at that particular age. And then the social worker goes into the classroom and has an opportunity to dialogue with the students around the stressors and coping strategies. Who are your supports? Who do you look for in terms of both adult and peers for support? What are some of the qualities that you're looking for in terms of the support? And then what are some good coping strategies when they're stressed? And then we talk a little bit about some of those inappropriate coping strategies, for example, the cutting behavior. And then the expectation after the social worker has done that in-service is that the class is divided up into small groups. And the expectation is for those students to then do some research around what supports are available in our community. Because as you can well imagine, across Windsor and Essex County, different communities have different supports. And we want the students to be able to research that, to find out what age group gets services, what services are available, is there a cost for the service, what hours are they open, can the student go without a parent, or do they need parental permission to be involved, all of those things. And then the individuals in those groups share that information so that the class has a true understanding. So we're trying to give them information, talk about the issue, and then provide them with the supports as well. And we've had quite a few requests from schools for us to go in and do that. Now, oftentimes, as you can imagine, when we have that conversation, then you get a number of kids who may disclose, and that's fine. That's when we respond again in terms of the crisis team. And then we connect those students and their parents to the appropriate services within the community. So again, having that dialogue and allowing the students to understand how they can support each other and how they can come up with good coping strategies for some of the things that they're dealing with. One of the things that we found in having our conversations with youth, and oftentimes even with some of the adults, is a lot of the concerns, as Dr. Ricciardi was mentioning, come late at night, on the weekend. They're chatting online, they're texting, they're on Facebook, whatever. And when we ask the students, if you're worried about a friend, if they say something where they may be possibly going to harm themselves immediately, what do you do? And many of the students have no idea. Some will say, I'll wait till I get to school and I'll tell the teacher. Others are worried, especially if they're online or doing something they're not supposed to, because it's 1 o'clock, 2 o'clock in the morning, and they don't want to wake their parents up. So part of what we've been doing with the students is having that dialogue as well. What do you do if you have that information? You've got to share it with a trusted adult. Who are the go-to people for you? And then what can you expect? And I think even for parents, it's really important for them to understand that if that information is being brought forward, then we have to take it seriously. And the students know that we do, and we need the parents to understand that it may, in some circumstances, require even a 911 call if you're that concerned about a particular youth. And we would always err on the side of caution and make sure that they're safe, than to minimize it and think, you know what, they'll be okay, we can deal with it in the morning. I don't want to call that parent and upset them. I don't want to disrupt the house. And so it's very important for us to empower the kids. And what we're starting to see is that some of these behaviors are happening younger and younger. The internet, it's a great resource. It's also working against us, because it's also something that they have access to, and they're getting information that is encouraging them to participate in these types of behaviors when they aren't necessarily the best choice for them. So again, not being monitored, because oftentimes they're accessing information without parents' awareness, and we're trying to give them the more accurate information about what they need to be doing to keep themselves safe and how they can support their peers. I'm going to do something I didn't do the last time we did this in the city, because I have the opportunity. The 3 individuals sitting right there are part of a new initiative. I love it when Matt talks about the fact that we have great partnerships, and the ministries are understanding mental health is really important as it relates to children and youth. The ministries have gotten together and decided that it's important for our schools to have mental health nurses. And so within our jurisdiction, we've been fortunate because they've just been hired. And so for our board, we will have 2. And for the Catholic board, 2. Ours are focusing on addiction. And so within 2 of our secondary schools, we are going to have access to the mental health nurse. And part of it will be education to students, part of it will be education to staff, part of it will be education to parents around addiction and substance abuse, even as it relates to mental illness. And as well, they will be linked to the students as needed, so students can access that on a voluntary basis, or through connections with the parents and school personnel. And they will also work as a liaison to connect them, if it's needed, to a community agency to get further, more intensive treatment. So we're working together through various ministries in partnership to address these needs, because we know how important it is, especially to deal with them sooner rather than later. So the younger we can get to the students who are exhibiting some of these issues, and the more that we can educate and prevent them from making those choices, the better it'll be for all of us. And so I'm glad that they were able to come out tonight. We had one of our first meetings today to talk about what it's going to look like. So we're pretty excited about that happening. And with that, I'm not sure if there are any specific questions from Matt or Phil or I, or even our mental health nurses, in terms of crisis and what we do in the community. I must share, because Matt, I don't think you made it clear, but the program that we have here with those hospital beds not being in the hospital is extremely unique in Ontario. And it is amazing for those students to be in that setting as opposed to being on the peds floor. Now, sometimes they're there for a day or two because Rotary Home is full, but it is amazing for them to be in that setting, to be able to be in there for a short period of time, have the service that they have, and then be back into their home school, to be back in their own home and getting the supports outside of the hospital. It's amazing that they've been able to do that, and it's been recognized in the province for being such a stellar program.